All right, so today I'm going to talk about, obviously, hollow viscous injuries in children, which is kind of an older term. It's really more blunt intestinal injury is what you kind of think of more than hollow viscous, because, and that's what I should have titled this, by the way. Blunt intestinal injury does not include the other hollow viscous, this guy, I guess, is the bladder and the ureters, which I'm not going to touch on this. That would be more of a genitourinary trauma lecture. But anyway, let's get started. So pretty much the problem with these injuries is that often they occur in patients that have had high energy type accidents, either motor vehicle crash or pedestrian or some type of direct blow to the abdomen, and they're commonly associated with other more life-threatening problems, and so they don't tend to be either picked up early or they may be overlooked because there's frankly something much more important going on. And the other problem with dealing with them is that there's no real single test or battery of tests that you can put together that's going to be very specific or sensitive. Pretty much the best test we have is only about 50% sensitive. Non-operative management that has become the mainstay in things like splenic injury, certain kidney injuries, and liver injuries has led to us having more of these delayed presentations of hollow viscous injury, because it used to be if you cracked your spleen, they'd cut you open and they'd run the bowel and they'd find an injury and they'd fix it at the same time as your other injuries. But we don't do that anymore in children, and even in adults we're more selective than we used to be. And then the signs of a hole in your intestine don't always manifest in the emergency room. I had 2 kids 2 weeks ago that I got called from the ER over at South about. They'd been in a wreck over there, and I think mom got transferred over, or grandmother got transferred over with a bunch of acetabular and pelvic fractures. And these kids were in the ER, and one of them had peritonitis and the other one didn't, but they both had seatbelt signs. And they both ended up getting operated on, one after the other, pretty much because the one that had peritonitis, that was an easy call. The CT scan showed just a little bit of free fluid, but no injury in the liver or the spleen to account for that fluid. So it was easy to go ahead and operate on that child. His little sister, I examined her before I took him to the OR, and I then examined her again as I was talking to mom after his operation, and she clearly had progressed. So it was, again, that was easy to take care of, and they had the exact same injury. Almost to within a centimeter, about this far from the ligament of trites, had a single hole in the jejunum, and they both had seatbelt signs. So we'll go over seatbelt sign here in a little while. So things that you commonly see in these patients is mesenteric injuries. We're not sure exactly what the actual incidence of that is, because lots of these don't go diagnosed, because unless you explore them for either ischemia or perforation or some other problem, we just don't always see them. We suspect that streaking in the mesentery on a CT scan is a mesenteric injury, but whether that's just a little hematoma or whether that's a frank tear of the mesentery is not known unless you actually open them up for some other reason. Duodenal hematomas have a pretty specific way that they present, and we'll talk about those. And then you have perforations of either stomach, small intestine, or colon, with the small intestine being the most common. So fortunately, these injuries are fairly uncommon. They only represent about 2 to 5% of blunt abdominal trauma patients that have had a significant mechanism of injury. Most commonly, and on your board exams, you'll see that jejunal perforation is the more common etiology, or more common injury, followed by the duodenum, and then either the colon or the stomach. There's not really good numbers on these, but jejunal is by far the more common. The etiology is felt to be usually a direct blow or a high energy transfer to the abdomen. Now we'll talk about seatbelt injury, but other things that you'll see, and sometimes on the pediatric boards you'll see, is a child riding a bicycle. You see these YouTube videos where these kids do these crazy things, and then they almost get impaled by the bicycle. In fact, we've had some kids that have actually gotten impaled by a handlebar. And this also you see with duodenal and pancreas injuries, and classically a transected pancreas is a popular board exam question for a child that's wrecked on his handlebars having upper abdominal pain. We do see kids that fall off of things onto other things. I've had a child who fell off a porch onto like a pole of some sort, and basically it didn't impale himself, but had a direct blow and caused him to have a pancreatic and duodenal injury. And then things falling on kids, and classically we hear of these, television sets that when we used to have the big tube TVs, and there were, or an aquarium or something on top of chest of drawers, and the child climbs up there to get to it and it falls, and then this whole thing hits them in the abdomen. And then sports injuries, if you get if you get kicked, baseball bat being thrown at you, elbows. There was a patient here recently that had a pancreatic injury secondary to being elbowed while playing sports. And then the thing that you really have to pay attention to is child abuse and neglect. It's actually the second most common cause of a perforated intestine in a kid from blunt abdominal trauma behind car crashes is child abuse. So you have to be looking for it, because sometimes the signs are subtle until they come in and they're very sick. So the two mechanisms that they describe is either a acceleration-deceleration event or compression of from the outside up against the spine. So you get these deceleration injuries at places where the bowel is fixated. And this would be near the ligament of Treitz, where the jejunum begins. It is firmly adherent there. You'd also see it in other parts of the duodenum and then parts of the colon that are actually fixated. And then compression between an external structure in the spine. The classic example is a seatbelt sign. And children that have an improperly fitted or placed seatbelt are at 4 times risk of, if that's in the history, their risk of having a blunt intestinal injury is about 4 times higher than it would be if you can reliably say that they were properly restrained. And then if you have a seatbelt sign on their exam, there are some reports of it, the risk being as high as 13 times what it would be if you did not have one. So seatbelt syndrome, as I said earlier, it's secondary to a poorly fitted or improper use of a seatbelt. And classically what you have is a child that's either not in a booster seat, and they have an adult style shoulder and lap belt that then rides up over the abdomen, or we don't see this as commonly anymore, or someone who actually has it on but has just the lap belt and doesn't have the shoulder aspect. But those cars we just don't see them, so we don't see that.
But kids put the shoulder strap on their back.
That's
because
right.
It rubs across their face.
Right. If they do that, yeah, and then that kind of creates this mechanism where they can hyperextend their torso. So basically, if the child's in a properly fitted seatbelt, the seatbelt should come across the top of the thighs, so that when the deceleration happens, it catches on their pelvis and the top of their legs and not up on their abdomen. And when it gets on the abdomen, it compresses all of the viscera up against the spine. I had a video actually from Japan where they were lobbying the government to, Toyota had made this video where they were showing this computer animation, and it was really because adult seatbelt standards and measurements and things traditionally have been made for the American market. And in Japan, the stature's slightly smaller, and so the problem is they were having elderly patients who were having the same injuries as children, but I couldn't get it off YouTube to be able to play it. But it's pretty interesting that you actually can see this in small adults. But this is most common in ages 3 through 9 because they're out of this nice protective seat, and they're supposed to be in a booster seat, but commonly they're not. We see these kids that are kind of flopping around in the back of the car, and if they're buckled, often you see this shoulder strap going up around their chin. So it's a classic injury complex. You don't see this all together every time, but if you see one of them, you should be thinking of the other. And I have pictures of these. You'll see a transverse bruise on the abdomen, and it's more like road rash where the seatbelt is, more so than a bruise necessarily. It usually looks more like a scraping across there. Sometimes you can see an anterior compression fracture or subluxation of the lumbar spine. One of the versions of this is called a chance fracture. Visceral trauma is very common, injury to the liver. Liver's a large organ in a child, relative to the size of the abdominal cavity, and it tends to lay lower than the rib cage in younger kids. As you grow, it becomes more protected. And then every now and then you see a child with a blunt abdominal aortic injury. Fortunately, they're not as common. So if you have a child that has a seatbelt sign from a motor vehicle crash, obviously, they have a chance of injury up to 50%. It's probably more in the 20% range, but there are some studies saying it's as high as 50%. This is the kind of the schematic of what happens. Basically, the fulcrum point, which is supposed to be right here, and basically push the force back this way through the very sturdy pelvis and lower lumbar spine, is pushed through the abdomen into the mid and upper lumbar spine. And that can classically, besides causing blunt injury or intestinal perforation or hematomas, can also cause this lumbar spinous process and vertebral body to basically just tear in half. And it's basically just extreme flexion like this, and those spinal ligaments are very strong, and if this happens too quickly, before those ligaments begin to give, you'll actually have tearing or just cracked in half, and then of course you can have other sequelae from that as well. This is what a lap belt sign looks like. Basically, here's the umbilicus. Normally, if this had been in a proper location, you'd see these marks on the edges down here. Sometimes people get in car wrecks, and you'll see these scrapes along the pelvis. Well, that's a seatbelt that was closer to where it was supposed to be. But you can see with this being up here, if you take someone who's about 50 pounds going 50 miles an hour and they hit an immovable object, that is a tremendous amount of force, and it just immediately just slices that. I've actually seen kids who've had their rectus muscles completely cut in half, and it's not uncommon to have a hematoma on the abdominal wall from that. So the need to operate on these kids is not always obvious when they present. Observation, serial exams are recommended after motor vehicle crash in children with a seatbelt sign, and some people have begun arguing this in the UK and Europe and had very specific criteria saying, well, if they don't have abdominal pain, their GCS is 14 or greater, they have no abnormal lab results, and these other things that you can watch them and send them home. And I don't really necessarily buy that, because a lot of these things will be asymptomatic and then later present. So at a minimum, if you're going to send someone home and they have a slight seatbelt sign, at a minimum you have to make sure that they have a way of getting back there in very specific criteria. Fever, abdominal pain, vomiting, any of those things. Personally, I think it's not that big of a deal to put someone in for observation, especially if other people in the car suffered major injuries. But with the way that medicine is going, at some point we'll have to answer to someone about putting these kids in the hospital. Until they tell us not to do it, I think it's reasonable to leave them in. And most of the mortality, fortunately, from these things doesn't come from the intestinal injury itself. It comes from these other associated injuries, mainly liver, spleen, and especially head injuries. The problem becomes is that these things can aggravate those things. It can make them worse by the patient getting septic and getting shocky. This is also debated now. They used to say, well, the mortality of missing an injury was 20, like up to 20%. And in reality, it's probably about the same as having someone with perforated appendicitis, with the exception that people with perforated appendicitis don't normally also have traumatic head injuries and other problems going on. So it's probably not as bad as we used to think it was, but it's still something that we need to obviously take care of, because if someone has that, they're not going to get better. But the sooner you take care of it, the less complications they have. This is just a slide to remind me to mention that what I said earlier, which is these are patients that had abdominal trauma, blunt abdominal trauma, that were not involved in a motor vehicle crash. And it's basically just to tell you that 40% of these kids in this study had abuse, and of all the kids in the study, 18% of them had a hollow viscus injury. So child abuse, very important to work up and to look for. Okay, duodenal injuries. The duodenum doesn't get injured as much as the jejunum because it's relatively protected. Parts of it sit behind or near the stomach. The transverse colon can be in front of it, the liver, other areas. It sits right on top of the spine, however, that makes it susceptible to being crushed. And it is relatively fixed, so if you have a deceleration injury, you can easily tear it. Again, as I've said over and over, on younger kids, always suspect child abuse if you have any type of duodenal injury and you can't rule out that they were in a car wreck or something else. Family, you find that on a CT scan, let's say a duodenal hematoma will be on your board exam sometimes, and you'll have that, and then the family won't give a good history, or it'll be a kid who's not able to walk enough to be able to, or ride a bike. You don't have any explanation as to why they have it. That's child abuse until you prove otherwise. So a duodenal hematoma, this is a compression injury, and it causes bleeding between the submucosa and the muscularis. And this may be partial or complete. The patient may have trouble eating, or the patient may just have frank vomiting. Vomiting is the most common sign. It usually is a delayed presentation, so either the patient comes in as, let's say, a trauma stat, and you work out other things, and then later they start vomiting a couple days later, they're not tolerating their feeds, then you might want to consider doing an upper GI or perhaps even an ultrasound, although probably upper GI would be the best test, I think. And then the other way they present is that a child who has a remote history of trauma a few days earlier, whether they got in a car wreck a few days ago, were cleared and sent home, starts vomiting, that sort of thing. Treatment's non-operative. You just decompress their stomachs with the NG tube, give them bowel rest and TPN. And this may take weeks sometimes to resolve. So you just have to be patient with it.
Do you have like a upper time period limit? I've seen 2 weeks and even 18 days for this to resolve. Do you have any?
No, I don't have an upper limit. I mean, you don't see them a whole lot. There's not a ton of them floating around, but I will wait as long as we can. I don't remember having to go in for someone who's obstructed. I mean, now I'll run ancillary other tests to make sure that I have the diagnosis right. In other words, I'll make sure that there's not some other cause for them to be, have that. But if I do an upper GI, or let's say a CAT scan, and I can see that there's a hematoma there, and things aren't going through, I'll give it quite a bit of time if there's no other injuries. Just because most of the time, once the hematoma resolves, it goes back to working again. And they may have a significant ileus. That's the other thing. So we've had kids who the hematoma goes away and they're still not tolerating their feeds. It takes a while. I'm not sure what the mechanism of that is. But I'd wait on those. It's not a good thing to operate on the duodenum. Anyway, here's a hematoma on scan, and then on upper GI, this is kind of an oblique or lateral view. You see that hematoma is partially occluding the lumen there. So perforation of the duodenum is usually caused by either a blowout injury or a shearing injury. A blowout injury in the portions that are not fixed, and a shearing injury in the areas that are more fixated. So you tend to see a blowout injury along the C loop, whereas in the other areas that are more fixed or hidden, the first, second, and fourth portions, I guess, are more of a tearing injury. They're always treated operatively. There's no other way to treat that. There's a whole discussion of how to treat a duodenal injury based, I think the main thing is based on what the condition of the patient is. A lot of times if you get it early, I just primarily repair them, even if it occludes the lumen about more than 50%. I'll try to primarily repair them just because most of those will eventually open up, but you may have to give them TPN for a while. Another thing to remember is that a lot of the duodenum is retroperitoneal, so you may have a delayed presentation, you may have peritonitis that is several days later than you think. And then again, as with most things, your complication rate depends on how long it takes you to find out what's going on. This is a picture of a delayed perforation. Here's the hole here. This is the duodenum sweeping around. Here's the gallbladder. Basically, you can see everything stained. Again, the sooner you get to it, the easier it is to fix and the better the outcome. Stomach injuries, they're pretty uncommon because the rib cage protects the stomach and as well as the liver. And the wall of the stomach is very thick. It's very mobile. It's very resilient. I've not seen a hematoma in the stomach. I'm sure they happen. I just think that the stomach's so big that probably, they probably go unnoticed. But perforation does happen, usually if the child has had a meal or if their stomach is distended, and it's basically a pressure phenomenon. And they almost always present with free air. It's easy to diagnose these on a plain film, whereas the other ones are not as common. Obviously, the treatment is surgical, and there's a low complication rate with repair. This is a picture. Here's the liver. The head's up here. The feet are down here, and along the greater curvature, it's just basically blown out right along there. Small intestine, jejunal perforation is the most common. You can also have them in the ileum. No reason why you can't. It's just the jejunum tends to live where the seatbelt crushes against the spine. Again, the mechanisms are very similar. It's either a blowout from it being compressed and the pressure going up so fast that it just blows out the wall of the bowel, or if it's directly squeezed against it. And then there's a late component to it, which is basically from a mesenteric injury, where you basically torn the blood supply, and it takes some time for that to then become necrotic and then perforate. The signs are less obvious with jejunal perforation. You're not going to see necessarily free air on your plain film. The fluid in the jejunum is not as irritating as the fluid from, let's say, the stomach or the bacteria from the colon, and so you may not have as many peritoneal signs as you would expect, and it may take longer to find these injuries. And with all of these, the main complications are sepsis, abscesses, and wound infections. This is a picture of this appears, I wasn't able to tell exactly what the history behind this picture was, but this is very red and inflamed. I suspect that hole's been there for a little while, and you can see where they've stapled across here and here to resect this area. So they obviously didn't think you could repair that given the condition of the patient. Colon injuries. The middle of the transverse colon can get crushed up against the spine just like everything else. They're just not that common. We don't see them as much as the small bowel injuries. The sigmoid colon is tethered, and so it can get a deceleration injury. You don't get blowout injuries in the rectum, although if you eat Buffalo Wild Wings, you might get a blowout. And there's no mesentery to be torn. So again, all of these, with everything, it's repetitive over and over and over again. Delay in diagnosis is common, and most of the problems become infectious. Commonly, we take someone back to the operating room for peritonitis, and all we find is a small tear in the mesentery and blood, free fluid or blood in the abdomen. And then you're kind of kicking yourself. You're like, why did I operate on this person? Well, don't feel bad about doing that. These things are a lot more common, I think, than we detect. And if you take someone back and all you find is a mesenteric tear, you shouldn't feel bad. Basically, and I wasn't able to find any hard and fast rules on this. To me, usually these things have been sitting around for a while, so if the bowel's ischemic, when I get in there, I just resect it. And if it's not ischemic, I fix the defect. If there's any question about it, I just resect it. Because basically, it's been sitting in there for hours or maybe even a day or so before you find it. So it's pretty much telling you its condition, it's best that it's going to be. So I've not seen catastrophic, trauma guys, I've not seen a mesenteric injury that's caused catastrophic bleeding. It can happen, but I think if you open the abdomen and you got a bunch of blood and you thought that you were going in there for a hollow viscus injury, which I think wouldn't be the case, you need to look other places first. I just haven't seen that. Now, I'll be operating on bowel and I'll cause catastrophic bleeding in the mesentery, but I haven't seen that from this necessarily. So when you get an injury in the mesentery and you basically shear these things, it appears that a lot of the big vessels, you can't really see it, but a lot of the big vessels seem to be preserved, and it's all the small little ones that tend to get obliterated, and you get these kind of watershed areas in between. And this doesn't project real well, but basically you can see as you come around at the middle, it's the worst right here, and then it gets a little bit better perfusion because it's getting some from the edges. But this whole area here is dead and is perforated because it's necrotic. So how do we evaluate these things? Again, most of these things don't happen in a vacuum. I mean, some kids come in and they got a handlebar injury, or they got hit with you know, with a baseball bat or fell on something, and you can point to the problem, and you know that's where you need to focus. But most of these kids come in and they have multiple injuries, usually from a car wreck, and they're hard to evaluate. So you just need to keep a high index of suspicion. Again, kind of standard stuff. You do the standard ATLS protocol. The history is important with these because if you know that the child was improperly restrained, then you know that their chance of having this injury is even higher. If they were properly restrained, then it can go a little lower on your list, especially if you don't have any outward signs. Again, the dreaded handlebar, direct blow to the abdomen, we talked about that, falls, child abuse. Look for the seatbelt sign. You also may see a localized bruise or hematoma. It's not always, a seatbelt sign is not always a perfect thing across. Sometimes you just see it on the sides or on one side. You want to know if they have guarding, rebound tenderness. I've never felt a duodenal hematoma, although it's been described that you can in really small kids. I just never seen that. And progressive bilious emesis, that is mainly if you have a remote history of trauma. Someone comes in and they're vomiting up bile, they just got in a car wreck. You're not going to be able to kind of say, oh, that's a duodenal hematoma. It could be any number of things. But if they were doing fine yesterday and they got in a wreck yesterday and basically were kind of checked out and sent home from the ER, and they come back today with bilious emesis, then you should put that pretty high up on your list. Whether you put an NG tube down is kind of based on your philosophy. There are some good things about it, though. I mean, you can kind of empty the stomach, and then you can also examine things better because the stomach, when it's full in kids, is so big that sometimes it presents as an abdominal mass and can also limit their ability to be able to ventilate them, especially if they're crying profusely. Something I forgot, and I just slipped in this morning when I remembered it, is you don't just get seatbelt marks on your belly. You commonly get them on your chest and on your neck. And although the incidence of blunt carotid injury in kids is lower than adults, I still think it's reasonable if you have that sign up there, especially if you're going to scan them anyway, to do a CT angio. I don't know what y'all's thoughts are on that, but I mean, it's such a high morbidity if you miss it that, you know, I usually would say, you know, at least consider that. And then of course you can get you know, blunt abdominal trauma. I mean, blunt chest trauma. You can also get aortic injuries as well. Lab studies. There is no good lab study for these things. You cannot diagnose it on lab values because everything that's abnormal can be abnormal for other things that don't necessarily need surgery. You can have a high white count, but that doesn't mean you need surgery. Your amylase, lipase, liver functions might be up. So what? Doesn't really mean anything. And urinalysis, you could have some red cells in your urine. I guess if you're not hypertensive, you know, what do you do with that? It doesn't really tell you. It's just that to remind you that other things get broken when the intestine gets broken. But I do think that the white cell, if you're observing somebody, the white cell count, I think, is helpful because although it may be elevated when they come in from them being stressed and acute injury and things like that, it shouldn't continue to go up after that. If it's 20,000 when they come in and then 12 hours later it's 30,000 and their belly's starting to hurt, I'd say you have a pretty good chance of having that, and I would definitely consider that highly suspicious. Free air is only present in a third of the patients on plain film, so they're not very helpful either. And that, you know, stomach injuries almost always have free air, but they don't happen very often. Portal venous gas, for the pediatricians in the room. Portal venous gas and pneumatosis is child abuse until proven otherwise, and a child that's not, you know, a newborn. If there's any kind of abdominal stuff, you need to kind of consider that. It's just not that common to get pneumatosis. Kid, you know, 2-year-old kid doesn't get necrotizing enterocolitis. You should consider that as a high possibility. And then duodenal hematoma, plain films don't help you because you don't get an air fluid level. You just have a stomach that has air in it. It looks like every other kid that's crying and getting an x-ray. Imaging, CT is our best test, but it's only good in 50% of cases. Only 50% of the time will you have extravasation of contrast or free air or bubbles of air near an injury. I don't suggest that people give oral contrast to trauma patients because I just don't think it helps and it takes forever. Do y'all do that? Just IV contrast? Yeah.
Unless there's something very specific.
Yeah. I mean, if you knew somebody had a duodenal hematoma, I guess, you know, you could do that and it'd be helpful, but you can usually see that without it. But if you do get a CAT scan looking for other injuries, or the patient's obtunded or whatever, things that hint at a bowel injury, bowel wall thickening, multiple fluid-filled loops, that's usually later on, mesenteric streaking, and then this is the one that always seems to come to mind, free fluid in the absence of solid organ injury. If you have a pelvis full of fluid and you don't have a splenic lac, you don't have a liver lac, that could be a mesenteric tear that bled and then stopped. A lot of times, about half the time it is. Or it could be that you have perforation. Let's see. Okay, CT only works 50% of the time. And then, as we were saying, even though the presence of solid organ injuries, which is common in children, may explain the finding of free fluid in the abdomen, it does not rule out the possibility of a hollow viscus injury. So even if you do have a splenic lac and you have fluid in the belly, it's impossible. This whole thing is impossible. It basically just comes down to following the patient clinically, unless you have a definite reason to operate. So what about fast exams? Everybody likes to talk about doing these focused abdominal ultrasounds, and they're helpful, but I just think in kids it may be less so. If your patient's unstable, it's a very good test, because you can tell, okay, did they have tamponade hemopericardium, or did they have a bunch of intraperitoneal fluid? That gives you a reason to not waste your time in the CT scanner and go to the operating room, for a blunt abdominal trauma. Now, if you have multiple system trauma, you may have to do that to rule out other injuries. But and a negative FAST in a stable patient doesn't help you, because FAST is at best trying to mimic or replace a CAT scan. So a CAT scan is only 50% useful. The FAST scan's never going to get up to that level. So I just don't think they're useful for this particular injury. What about DPL? We don't do DPL in kids very often. And if you've ever tried to do a DPL in an adult who's not cooperative, imagine doing it in a child who's not cooperative. The other problem is, a FAST exam is quicker than that. So if you just need to know, is there fluid in the belly or not, FAST exam is good for doing that in a patient who's unstable. Also, when you do that, you always put some air in there, and you put fluid, and so you don't know in follow-up studies, okay, is that free air? Is that air I put in with my DPL? Is that fluid? Did I do that? Kind of thing. Now, I will say that if you have a child, let's say on ECMO, or you have a child that has got such bad lungs, or some reason that they're too unstable to move, and you need to know, okay, do they have a perforation or not? I think a DPL is useful. As patients aren't going to move, for one, so you can do it, and two, it's really the only other thing you can do is just either not operate on them or operate them on the bedside. So the DPL in those patients, which is rare, you don't see that often, would be a use there. Management, ATLS, AVCs, just like usual. If it's unstable and you think they have a hollow viscus injury, and do emergent laparotomy, but really, if they're unstable and they have fluid in their belly, you might look for this, but you're thinking of other things. They still need an operation. And if they're stable with clear signs of peritonitis, then you have to figure out, okay, do I want to do a laparoscope or a laparotomy? And we'll talk about that. But if they're stable, and let's say they have seatbelt sign, but they don't have, the CT scan's negative, and on exam it's just not real convincing to you, or you're not sure, then observe them. You're not going to, observing them for 6, 12, 24 hours is probably not, even if you miss the injury and operate on it a day later, is not going to be as bad a problem as it would be if you sent them home and several days later they come back, crashing. Because you're going to be watching them. They will get worse. So if you're going to observe them, keep them MPO, don't feed them. Keep them well hydrated. Don't give them antibiotics, and do give them pain medication. The serial exams that need to be done by the same person. It needs to be someone who's familiar with peritonitis. So don't send an off-service intern to go do not routine, but serial abdominal exams, because it's not fair to them, and it's not fair to the patient. Send a senior, a third-year resident, second-year resident, somebody who's examined plenty of abdomens to know what is and what isn't peritonitis. I usually do them about every 6 hours or so, and if you give them pain medication, the anxiety may be less. You may be able to get a better exam. And I usually check the CBC usually the next morning, or if the injury is early in the morning, in the afternoon. Subjective signs of injury, if the abdominal pain is getting worse, and objective signs, fever, tachycardia, leukocytosis. If you don't have an explanation for those things and you suspect that they're at risk for injury, then you need to be very vigilant and keep a very close eye on them. Pain management, I usually start at the low end of the scale on morphine and work up as long as I'm not sedating the patient excessively. I don't think it masks peritonitis. When kids get observed for, let's say we think they have appendicitis, or they had a CAT scan that's equivocal and we're observing them for appendicitis, I'll give them low doses of morphine to keep them comfortable, and I have not found that causes any problem determining whether they need an appendectomy. And there's several studies that have said the same thing. And I'd actually rather than get morphine than ibuprofen or Tylenol, because fever in a trauma patient, it has no other reason for fever, is pretty helpful to me. Now, suspected abuse, this is mandatory. You have to report abuse. Again, we're all pretty familiar with this because we've seen it, and it's a pretty standard set of things that you want to do for it. So operative management. So which surgery do you do? Well, a lot of people will tell you to do laparoscopy, and I think that's a good thing to do if you think the chance of the child having the injury is pretty low, and you just need to prove it to yourself or prove it to your team. And if you do find an injury, it's pretty easy to fix these. The kids, their bellies are very stretchable. You can go in with a scope, find the injury, grab it, pull it up through the port, and once you've kind of identified that that's the only injury. Grab that piece of bile, pull it up to the port. You can enlarge that incision slightly. You can pull it all out, resect it all right there, and stuff it back in. That's how we do bowel resections in kids that have strictures and things like that. And it's really not that hard because their abdominal walls are not very thick. Some adult with that, and that's a different story. But so don't let that be a reason if you're like, well, I won't be able to throw the stitches intracorporally. You don't have to do that. Just pull it out and do it like you normally would do it, and then just dunk it back in there. And about half the time you do laparoscopy, you're not going to find another injury, or it's something that doesn't repair. So there's a good argument for doing laparoscopy in stable patients. If someone's unstable, you obviously just do a laparotomy. But I don't think you should feel bad about doing a laparotomy in any kid for this problem. Because you can do it with a little incision, like those two kids that I talked about a couple of weeks ago. I did both of them through a little 2-inch incision, because basically it works as a keyhole, or it's a keyhole incision just around the umbilicus. But you can move that incision around. They're so stretchy that I can move that thing around and basically look at everything. I was even able to look all the way up and evaluate the diaphragm and see the diaphragm. And you can, in a kid, non-teenager type kid, you can easily with that incision get your hand at any part of the abdomen, and you can eviscerate all the bowel, and then you can see that we were able to cauterize the duodenum and do all the normal procedures. So don't think that I just would not start with a big incision. Just make a small one. You can make it bigger if you need to. These are kind of redundant. We've been talking about these things. So this is really the most challenging group of them, and there's not a really great answer for, are the head injured or intubated patients. And basically, the problem is they don't have any subjective symptoms. So you're pretty much stuck with, okay, I've got a CAT scan that was negative. The kid's intubated because he's got a bad head injury. He's spiking fevers. His white count's up. I don't know what's going on. And when he came in, he didn't have a seatbelt sign. He didn't have any other findings. On those kids, you just have to keep examining them, and at some point, you may just have to operate on them. And that's, again, where a laparoscope might be helpful. But just remember, whenever you have a head injury, negative laparotomy, even insufflating the abdomen, can be harmful, because if you cause hypertension, you may cause secondary injury. But if you don't catch the problem and they get septic, they're going to still need an operation, and they're going to have the problem of the sepsis on top of the brain injury. So basically, anytime at the end of this is the end of the thing, but anytime you see bruising on the abdomen of a child, it's a significant energy transfer. I treat it like I think of it just like rib fractures. Kids shouldn't get rib fractures unless they're hit pretty hard, because they're very pliable and energy gets transferred very easily. And if you hit someone in the stomach, that energy is going to go in. It's the excessive energy that creates the bruise. So pretty much, if you have a bruise on the child, you should consider that there's a significant transfer of energy, especially if it's just one spot. Like if you have a handlebar print right there, that's a lot of energy in one place. So again, most of the time you have to make the diagnosis yourself. And then if you're in doubt, do serial exams. And again, those kids that can't talk or intubated, the ones that are the most difficult to take care of. And then don't forget that child abuse is the second most common cause of these injuries. That's pretty much it. Sorry it's so redundant and that it's not clear, because it's not. But pretty much that's it. Any questions about anything? Okay.
About the routine imaging, specifically CAT scans and blood trauma for the pediatric population.
Yeah, I mean that's always I mean I'm guilty of overscanning people. You know, I'm old school. I know that there's a significant risk for kids to get cancers from excessive CAT scans. I don't know if I buy that it's 1 in 1,000. You know, but I can't say that it's not. But I think it's much worse to miss an injury than have a 1 in 1,000 chance. Now, I think if you have any of those signs, if you have bruising on the abdomen, any of that stuff, that's definitely scan those kids. Otherwise, you know, what's proven to be a better test than scanning them is observing them and doing serial exams. So just like we used to do with appendicitis, there were kids that we admit that we know they have appendicitis, so we take them to the OR, and a lot of times we get consulted on them because they've already gotten a CAT scan, they have abdominal pain, but yet the CAT scan's equivalent. They didn't give contrast, or they can't see the appendix, but the child's tender there. And those kids get admitted, and we'll examine them a couple times and see. So that's probably the answer to that. But there's so many other reasons they get scanned. But the fast exam is the thing I've never been able to kind of really know where it fits, except an unstable patient. I think is, you know, I think it's very helpful for that. But what in adults, are y'all still doing a lot of fast exams?
Too fast to everybody.
Fast to everybody.
I mean, it's a piece of the puzzle. It's not an absolute answer.
Yeah.
But it's one of the things that helps.
But that's reduced your CAT scan requirements.
Well, we probably can't
think
scan
so?
everybody.
Yeah. No? Can't?
Well,
He says no.
partially we fast them because it's a trade teaching hospital.
Yeah.
And,
Mm-hmm.
and it doesn't cost anything, and it's totally non-invasive.
Yeah.
But no, I don't think it's reduced our CTs.
Yeah. It's hard to...
You think it's reduced CTs? Okay.
Just for everybody else, the problem with, if let's say you're the ER physician or you're the radiologist, it's easy to say we don't want to radiate all these kids, and it makes sense. The problem is the person that has to kind of make the final choice, and the person whose conscience, I guess, it lies on if you miss the injury, is the surgeon. And so I think that's why we're way overdoing this thing. But I just couldn't find a lot of information that said any particular test that would help for these things. In that study, I think it was out of the UK, where they had all these criteria. The meatless criteria, their chance of injury was, let's say, like 5%. You send them home. That might be true, but I mean, maybe that works in a place if people can get back to the hospital easily. But so many of our patients are scattered out, and so many of them don't even come to their clinic appointments. I mean, to think that, you know, they went to the hospital, the kid got checked out, he's fine, and now he's got belly pain again. He had belly pain last week. No, it's nothing. You know, it's just a real nebulous area. So.
Can I make a couple of observations? Yeah. Fast scans in pediatric patients. When I was a fellow, it was taught to me, and granted this has been an eternity ago, that kids, and you guys as surgeons could help tell me yes or no, that their little capsules on their spleens are denser than those in adults. Maybe, maybe not.
Yeah.
And thus, quite frequently, you are going to miss a spleen injury on a fast scan. And I can attest, and I've seen more of the times than I can count, spleens that are absolutely macerated on CT, that fast scan, I've done it, and it's stone cold normal. There's nothing on it. Second thing I just want to bring up too was the CT scans, the pan scans in the pediatric patients. Those are the bane of my existence. Biggest misses I've ever had have been in little kids, non-contrasted, and honestly I wouldn't think contrast would make a difference. CT of their abdomen and pelvis. They don't have intra-abdominal fat, so finding fluid in these kids is next to impossible. And again, the best from imaging standpoint is look, is there fluid in the pelvis? Is there intermesenteric leaf fluid? It's pointed. You can tell it looks different than bowel. And that's pretty much it. I mean, looking for wall hematomas or an actual bowel injury itself is just, Dr. Hellman might could find it, but the rest of us normal people, it's next to impossible.
We try to encourage always at least IV contrast.
Yeah.
I mean, oral contrast, one problem is it delays, in a trauma patient and kids, it delays it. So many of them vomit it up, or you have to put an NG tube down to do it and all that. But yeah, I tell people never get a CAT scan period of the abdomen without at least IV contrast, because in a kid, because you don't have intraperitoneal fat, so you don't. I mean, the whole thing that we're looking at with most of these, at least with like appendicitis and stuff, we're looking for stranded, and we're looking for an abnormal. Because you can't, a lot of times you can't see the appendix, even if it's abnormal, if it's stuck up against the cecum, and you got all this contrast and stuff in there, you can't see it well. And so, whereas adults have lots of fat in there, and when the fat gets inflamed, it has a very characteristic appearance on CT scan. With kids, you can have a belly full of pus, and all you see is just what looks like a little bit of fluid floating around. You open them up, and it is just all pus. We see it a lot. And without IV contrast, it's hard to see all the inflammation that's there.
Yeah, I mean, quite frequently with these children, I feel like I'm trying to read with one hand tied behind my back, and it's just because the no fat issue, it's just soft tissue. You can't tell anything. But another thing to remember too is when, if you guys get frustrated with us that we can't give you a positive call or something, another thing that affects this imaging is that we use the image gently with these children. So their technique, their radiation dose is cut sometimes to the point that, I want to beat my head against the wall that it's almost non-diagnostic.
Yeah.
And this is in response to the media and the reports, with the kids getting cancer, increased cancer risk, and all this kind of stuff. So there are several factors that not only are these scans difficult for us to interpret and help you guys with, but we have several significant limitations that limit their ability to be able to give you definite diagnosis.
I just don't see why you can't do IV contrast. It doesn't take any. The ER guys swear, you don't need it. You don't, for all these things.
They don't read it.
Well, they don't. When they're not the final. They're not the final. Yeah, exactly. But even the radiologists, in the private world, are kind of supporting them on this. And I think a lot. I know why oral contrast they want to give it, because those guys get graded on how fast they get that patient from point A to point B. And if you give 2 hours, for contrast to go down, it makes them look like the worst doctor ever, because they
And at the same
get
time,
clogged
are
up.
you want to give radiation for a diagnosis that you might can make better if you did that? That's
Yeah.
a question, not
Yeah.
too. In a perfect world, I would give IV and oral to everybody. But the problem with oral is that we can't give enough and wait long enough to pacify the entire valve. So it doesn't do any good. Now, if you had a stable patient, that you could put contrast down and give them a secondary dose and make sure that the whole valve is pacified, that would be great. But, in real life, it's not going to work like that. So.
Thanks. Okay. All right. Thank you all. Have a good day.